The first topic we're going to cover this week is disorders caused by dementia. The term dementia itself is very broad. It refers to the results of a number of different diseases, all of which lead to a loss of intellectual abilities. Dementia is caused by the deterioration of brain tissue. Different forms of dementias affect different parts of the brain. Dementias do not cause damage in specific focal sites the same way that aphasias do. Rather, they appear as a more generalized atrophy of brain tissue. So we're going to start out by speaking about cortical versus subcortical dementia. Cortical dementias are caused by damage to the cerebral cortex, or the outer part of the brain, as you can see in this picture, and subcortical dementias result from damage to the subcortical structures of the brain. The most common form of cortical dementia is Alzheimer's disease. In Alzheimer's disease, the characteristic changes in the cortical cells result in patients showing at least 3 of the following 4 symptoms. They present with problems with language, they have memory problems, they have problems performing new tasks with knowledge they already know, so for example, spell the word world backwards, and they have personality changes. Additionally, many individuals with Alzheimer's disease become more irritable and even belligerent. However, there was one instance in which an adult daughter complained that her mother, who usually was quite critical, had become very nice with Alzheimer's dementia. The most frequently occurring form of subcortical dementia occurs in approximately 1/3 of cases of Parkinson's disease. Individuals with Parkinson's present with difficulty in general with their movements. Their gait is characterized by slow and halting behavior, and this slow and halting behavior extends to their control of their vocal apparatus as well. So individuals with Parkinson's present with dysgraphia, or a disturbance in their ability to write as well. For example, their writing samples exhibit both micrographia, which is a tendency to write in very small letters, and an inappropriate use of space in their writing. However, both of those symptoms could also be attributed to their loss of muscle control. So as I mentioned earlier, we can also expect some cognitive changes in the 1/3 of patients with Parkinson's disease that also have dementia. Their form of dementia consists primarily of memory problems and problems operating on the knowledge that they already have. And these individuals with subcortical dementia also present with some subtle effects on their language. So below you can see a phrase written in quotation marks, and that was an example of a patient with Parkinson's written description of the Boston Diagnostic Assessment cookie theft picture. And so what we can see here is that 3 out of the 4 errors in this sample were involving morphological word endings. So Parkinson's disease has an average age of onset of approximately 60 years, although a juvenile form does exist. And the reported incidence of dementia in patients with Parkinson's disease is variable across studies. In terms of diagnosis of Parkinson's disease, it is characterized by reduced dopamine levels, degeneration of nuclei, widened sulci of the brain, loss of cells from the substantia nigra, and the presence of Lewy bodies. In terms of their communication, it's typically affected by hypokinetic dysarthria, which has hypophonia, a rapid rate, vocal tremor, monopitch, and monoloudness. Additionally, individuals with Parkinson's present with naming problems and impaired discourse comprehension, and as I mentioned previously, that micrographia, which is the writing in extremely small letters. In terms of behavior, individuals with Parkinson's disease typically present with immobility or slow voluntary movements, diminished facial expression, resting tremors, increased muscle tone, and resistance to movement. They also have disturbed gait and posture, memory problems and confusion, hallucinations, and executive dysfunction. Socially, they may become apathetic, depressed, withdrawn, and have anxiety. Two other forms of subcortical dementia are Huntington's disease and multiple sclerosis. So, Huntington's disease has a gradual onset, and the rate of progression and age of onset vary from person to person. It's an inherited neurodegenerative disease caused by mutation of chromosome number 4. A genetic test is available for an accurate diagnosis, and individuals with Huntington's disease present with a loss of neurons primarily in the basal ganglia. In terms of their communication skills, individuals with Huntington's disease will present with naming difficulties, a use of shorter and simpler utterances, grammatical errors, difficulty comprehending subtle aspects of discourse, dysarthria of the hyperkinetic type, including variations in loudness, monopitch, and harsh voice quality, and mutism in the final stages. In terms of their behavior, individuals with Huntington's disease will present with excessive complaining, they'll become eccentric, irritable, they can have emotional outbursts, violence, and extreme confusion in the final stages. They will have spasmodic movements and involuntary movement of the limbs, neck, and head. Additionally, they can have impaired memory, attention deficits, and slowness with all intellectual activities. The final form of subcortical dementia that we will speak about is dementia related to multiple sclerosis. Multiple sclerosis is a chronic neurological disease that affects the central nervous system. It's caused by damage to the myelin sheath and inflammation that occurs when the body's own immune system's cells attack the nervous system. It's primarily a white matter disease, but it may also involve gray matter. Individuals with multiple sclerosis will have some communication issues such as dysarthria, including unclear articulation, difficulty controlling loudness, and poor pitch control. Additionally, they can have problems comprehending and using language related to cognitive changes. In terms of their behavior, individuals with multiple sclerosis will have fatigue, vision problems, weakness, gait issues, balance and coordination problems, and pain. Additionally, they may present with dizziness and vertigo, and they can have emotional changes, anxiety, depression, and cognitive dysfunction. So now I'm going to speak about a few of the common cortical dementias. As I mentioned earlier, Alzheimer's disease is the most common form of dementia. It likely occurs after the age of 65. It can be familial or non-familial. It can coexist with other conditions such as Parkinson's disease. In terms of communication, aphasia is common, which starts as either fluent or non-fluent. The semantic system is most affected, and syntax and phonology are affected later. Language comprehension deficits occur. There's difficulty with topic maintenance, echolalia, lack of meaningful speech, and a gradual progression to mutism. And in terms of behavior, individuals with Alzheimer's disease can present with depression, insomnia, incontinence, delusions, agitation, restlessness, hyperactivity, disorientation, delusions of persecution, and loss of initiative. Next, we can speak a little bit about vascular dementia, which is another form of cortical dementia. It's also called multi-infarct dementia, or MID, when there are multiple lesions or infarcts present in both gray and white matter. It is caused by multiple strokes and some without noticeable clinical signs. The symptoms can begin suddenly and progress after each small stroke, and this form of dementia sometimes co-occurs with Alzheimer's disease. Individuals with vascular dementia can present with motor speech disorders or slurred speech, word retrieval difficulties, and difficulty following instructions. In terms of their behavior, depression and mood changes are often noted, along with confusion and problems with short-term memory. These individuals also can wander and get lost in familiar places and have impaired coordination or balance. Next, we'll talk about Lewy body disease, another form of cortical dementia. Um, Individuals with Lewy body disease have periods of normal cognition, and these alternate with abnormal cognition. This follows a progressive course, which is often rapid. They also present with motor speech disorders with hypophonia and disorganized speech. And in terms of their behavior, individuals with Lewy body disease, they can have visual and auditory hallucinations, pronounced fluctuations in alertness and attention, periods of delirium or confusion, and daytime drowsiness. They also can present with Parkinsonian motor symptoms, so rigidity and loss of spontaneous movements. Another form of cortical dementia I wanted to discuss with you guys is primary progressive aphasia. So, individuals with primary progressive aphasia, or PPA, will gradually lose their language function while maintaining a relatively well-preserved memory, visual processing skills, and personality until the advanced stages of the disease. So the effects on communication of primary progressive aphasia typically begin with word-finding problems, and then they progress to impaired grammar or syntax and comprehension. So they have issues with sentence processing and the semantics. Additionally, symptoms associated with impaired speech production can also be present. So they could have dysarthria and apraxia, for example. In terms of behavior of individuals with primary progressive aphasia, these individuals typically have their activities of daily living, judgment, insight, and behavior totally spared until the late stages of the disease. Finally, I wanted to speak a little bit about Pick's disease. That's the last form of cortical dementia we're going to discuss. The onset of Pick's disease typically occurs before the age of 65, and it follows a slow, progressive course. In terms of its effect on communication, individuals typically present with reduced speech output. Their speech is non-fluent. A progressive decrease in expressive vocabulary, so some word-finding deficits, reduced spontaneous conversation skills, and echolalia and meaningless repetition of phrases. These individuals also present with a wide range of behavioral changes, executive dysfunction, and personality changes, and uninhibited behavior, including inappropriate social behavior. And additionally, they can present with depression, irritability, and mood fluctuations. So in conclusion, in individuals with subcortical dementias, the problems are most obvious with their speech rather than their language. However, these individuals can present with subtle issues in naming, lexical selection, list generation, and morphology in writing, and sentence comprehension. On the other hand, in cortical dementias, especially those in which begin at a young age, the language problems are more evident. These individuals with cortical dementia can present with severe deficits in their lexicon and semantics. Additionally, their pragmatic abilities, such as responding when a question is asked and maintaining eye contact, are spared until relatively late in the course of their disease. However, more complex pragmatic skills, such as inferencing or monitoring a conversational partner's baseline knowledge, those disappear. And non-language aspects of cognition, so in particular decline in memory, attention, and the ability to manipulate ideas, these contribute heavily to the linguistic decline of individuals with cortical dementia.